And the people who wouldn't be able to pay or shouldn't be expected to pay are probably more likely to be the ones who will be accessing the healthcare more. There has been quite significant underfunding in a lot of areas within the NHS. We have an era of austerity. I wonder how long the NHS is going to be sustainable. Who is going to be brave enough to bring that in? The danger in prescribing above the licensed dose is that we don't know what effect that higher estrogen level may have on the body. They may feel more on edge and not really having any particular reason why they feel anxious, but they just have that slight inherent anxiety feeling. I get a lot of older women who will quite often say to me in a consultation, you probably think I'm a bit old for all this, but...
Someone told me the other day that if we all open up about our sexual and emotional issues, the system will collapse. Hi, I'm Hala, your host today. We'd love your support. A quick subscribe to this channel would mean a lot to us and help us grow. We may be small now, but with your support, we can achieve something amazing together. Thank you.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being.
Let's talk about the NHS.
Okay.
We have, of course, integrated the NHS into our talk, but NHS, one of my favorite subjects. I know that the bigger the organization, the more cracks it develops, and over time it becomes increasingly difficult to fix things. Having said that, it's not impossible to have an efficient, self-sustaining organization. We see that happening in Dubai every day. Why is it so difficult to optimize the NHS?
It's a really difficult question to answer. There are so many. There are so many factors that are at play here, and so many factors that have created the situation that we find ourselves in now in 2025. There has been quite significant underfunding in a lot of areas within the NHS. We have an era of austerity. We know that there are significant problems with regards to staff recruitment and retainment of staff. We know that due to inflation, staff wages, running costs of hospitals, all of these things have significantly increased, which causes a problem. And then we know obviously the legacy of COVID and how that's created these enormous long waiting lists. So all of these factors are all playing a role in the difficulties the NHS is having. There's also just a hugely increased demand. We have an aging population. We have a lot more chronic health disease than we used to have because we are getting better at treating conditions. People are living for longer, but they're not living for longer in a healthy, independent way. So enormous amounts of money is having to go into caring for these people and into their social care as well. So,
well, you touched on staff retention, doctors and nurses, but one of the things I've learned having this podcast and speaking with local doctors is that a number of them feel disillusioned with NHS. And I thought, surely that's how big organizations lose talents. How can this be fixed? I mean, we know the admin work, the long hours, underpaid, but this again leads us to funding, right?
I think so. And it's just creating environments that are supportive. I think generally the staff that work in the NHS are all very amazing people who all work very hard and are all very dedicated. Obviously during COVID, there was a lot of pressure put on certain services, and that was very difficult. And I know a lot of doctors and nurses, or all health professionals, there was a degree of burnout as a result of that. It is very difficult. I think there's just so much pressure. There's a lot of firefighting that goes on a lot of the time.
What do you mean?
As in, you're just trying to get through the workload each day that's coming at you, and therefore you don't really have the time to sort of look at all the other factors that are important. You're just looking at the acute patient in front of you, dealing with them, and then finding the most appropriate treatment and looking after the quantity and the numbers, and you're not actually often looking at the big picture. And I think that's part of the problem, that everybody is just so busy, everybody is so pushed and so pressured that it doesn't leave much time to be able to discuss and look at how we can change things, how we can make things better.
Believe it or not, when I moved to this country 15 years ago, I didn't know that the NHS is free. And I remember I was super, super overjoyed that it's free. Wow, I don't have to pay for it. Do you think the NHS should still be free?
Well, this is a very political hot potato, isn't it? I think there's lots of arguments for and against that you can explore. The concern, I think, mainly is one of the arguments that has often been put forward is whether they should charge people for primary care access and A&E access. So should we be charging patients to come and see their GP and maybe when they attend A&E? The concern about doing that obviously is that it will be a disincentive for people to seek healthcare, and then they will neglect their health. They will then end up becoming more unwell and will then need secondary treatment, which will then often be much more costly than the preventative treatment that could have been given to them in primary care. There is some argument to suggest that maybe just the people who can afford to pay for treatment should be paying more, and that should be means tested. But then the argument is that to put in the systems to be able to allow that to happen would also be incredibly costly, and therefore there might not be much of a saving in putting in that administration that would be involved in that. And the people who wouldn't be able to pay or shouldn't be expected to pay are probably more likely to be the ones who will be accessing the healthcare more, just in the fact that they will often be older in a lower socioeconomic group or have chronic health disease. So I wonder how long the NHS is going to be sustainable to be able to, when it was first set up, the whole system, the whole, healthcare was so incredibly different to how it is now. And
how different? Well,
we just didn't have the medications, we didn't have the medicines, we didn't have the equipment, the types of healthcare systems that we have now are so advanced compared to what they were like in the 1940s. So just being able to afford just the medications and the drugs that we prescribe now is taking up an enormous amount of the budget. So things are just very different. And whether it is going to be sustainable long term, it's just, we may have to start to look at ways in which we have to start paying for some of the services. But who is going to be brave enough to bring that in? It's going to be a very brave politician. Exactly.
Yeah. I was also surprised 15 years ago that there isn't a unified, comprehensive computer system that has everyone's medical histories from birth to present day, coming from Egypt. And I thought, okay, the UK, everything's so advanced kind of thing. Yeah. I had already registered with a surgery. My very first visit to hospital, I totally assumed that they knew everything about me because the hospital and the surgery both in the same city. I mean, but I had to tell the consultants all my previous diseases, and he invested a lot of time in his investigation. God knows I was accurate or not. We don't know. But I was really, really surprised that there isn't this digital connection between my surgery and the hospital. Yep. And going forward, the last 15 years, I kept a diary and I kept folders and folders of everything I have, because I know that now I have to be the agent of my health. Yep. So if I end up in a new place, I know what I'm talking about, and give accurate information. What's holding us back from having such a database for everyone? I
think it's a cost issue. So to have a unified system that all hospitals and primary care could use, it obviously would be extremely expensive to put that in place. And I just think the budget is not always, that's not always seen to be the top priority. And I think there's also enormous implications regarding data protection and security risk as well. So
ideally, those who will access data are doctors as well.
Yes, but I think it's just in terms of leaking of medical information, because it's highly sensitive information, you have to have extremely strict, guidelines and protocols about how that information is acquired and shared. So I think it's quite a complex situation, but I do agree with you. And I think people are often quite surprised when they go to different hospitals that they'll say, well, I had an X-ray done here. Can you not see the images? And no, those images belong to that hospital note and this hospital. Then it does mean that quite often tests will be repeated, which is a bit of a waste of resource.
Yeah, and the time in investigating everything as well.
Yes.
Yeah. The Visionary is not a political podcast, but when it comes to the NHS, it is very much political. For an institution that everyone uses and everyone benefits from, we don't talk about the NHS enough. There has to be more talk about efficiency, performance, funding from a place of positivity, to fix, to repair, not to demolish and build again. I'm not a fan of revolutions.
Yeah.
Hopefully from people outside the system like myself, stakeholders and doctors from within the system, like this conversation that we're having. It's very, very useful. Do you use NHS yourself?
Yes.
With your children?
Yes.
Do you go into an appointment diagnosing yourself already before you...
I don't go that often. I'm fortunate enough that I don't need to go that often. And yes, generally, when you go and talk to a doctor, they will say, well, they'll ask me, well, what do you want to do? Or what do you think about this?
That's funny. How do they know that you're a GP?
Well, this is a problem. So I live in a relatively small community as well. So when you've lived in an area for long enough, you pretty much know all the local doctors. And so it's difficult, and I find it slightly difficult when I see a patient who is a doctor as well, because you want to maintain that very professional stance, and you want to treat them as you would any other patient, but you are aware that they obviously are going to have their own ideas and assumptions. So it kind of is difficult both ways. But yeah, we have to. I mean, it's important that we're registered with an NHS GP and that we access healthcare when we need it. Yeah. So yeah, we have health problems just like anybody else. Yeah.
We'll move now to our lovely, complicated reproductive system. Female hormones, they play a huge role in our lives. They steer us, they guide us every step of the way, and often not in a straight line. What are we missing from the conversation around hormones?
I think at the moment what we don't have is a very large database of knowledge about exactly how our hormones are affecting us over a period of time. So when we take a hormone test from a woman, or from a man, from anyone, you're taking literally a snapshot on that day, at that moment, at that time. And if you took that blood at a different time on a different day in a different part of the cycle, you would get a very different profile. And so it's quite difficult to be able to use that information to be able to understand how that's then impacting us with certain other symptoms that we're having and try to correlate that. And it is exciting that there are now techniques that are starting to be developed where we can start to test those hormones more regularly throughout the day on several different days throughout the cycle. And there's some really exciting projects that are being done to really then start to understand how that impacts us. I find quite a lot of women will come to talk about hormones, and it is difficult to be able to explain to them that at the moment we don't really fully understand exactly how their hormone profile is fluctuating for them. It's very individual for each person, and we don't have a way of testing that.
Why aren't we being instructed to have the test on a certain time in our periods, whether before, in the middle?
You would be for certain conditions. So for example, if I wanted to see if you were ovulating, I would take a test and I would suggest you did it at a particular time in your cycle when I would be expecting that. But particularly through perimenopause, for example, when hormones often are fluctuating, you don't really know you might not know where you even are in your cycle. Or if you have polycystic ovaries, for example, you might not know where you are in your cycle. And so you're having a blood test done and it might show a completely normal result, but it doesn't actually mean that means that you're not experiencing significant fluctuations in hormones. So I think we are very much in the infancy of trying to really fully understand exactly how our hormones are impacting us, because we just don't have the ability to test it.
I wanted exactly the same when I approached my GP. Was it 3 years ago or something? When I started with the hot flushes, they did the test. The service is there and they're helpful and everything, but they didn't know where I am in my menstrual cycle.
No.
And I received a phone call telling me that my hormones are brilliant. You're like a 30-year-old woman and all that, but I had it at the back of my head nagging me that they don't know where I am in my menstrual cycle.
And they can't, and I say this we don't often routinely take bloods for that reason, because they're not for hormones, because they're not particularly helpful. And at the moment, we have to really be guided by symptoms rather than actually understanding exactly what we know that their symptoms are likely to be because of what is happening with their hormones, but you can't necessarily take a blood test to check that. So quite often, women will come to me, for example, in perimenopause, and some of those women will be often in their early 40s, and which we now know that a lot of women have perimenopausal symptoms in their early 40s, but traditionally, often women would be dismissed and told, you're too young to be going through menopause. It can't be, you're still having regular periods. They would do a blood test and it would show completely normal results, but that's only just on that day at that time. But in another month, it might show a completely different result. So that's what we're missing, really. We're not missing the data to fully understand exactly how these hormones are impacting us at different times in the cycle.
Again, I still want to drill down on this bit. So what is the ideal scenario to take or to test hormones, like, I don't know, off the top of my head, 3 points in one cycle, then 3 days in the following cycle? Surely this is a logistic nightmare for the NHS.
Yeah, I mean, this would not be possible on the NHS. Yeah. So at the moment, we would advise against really testing for, I mean, obviously there may be health conditions where we might need to test for different hormones, but if we're talking specifically about our female sort of sex hormones, we, at the moment, we just wouldn't advise it, particularly for conditions like perimenopause, because it's just not accurate and it doesn't help us at all. We can sometimes, for things like polycystic ovaries, you can test at certain times in the cycle that will give us a guide as to whether that might be more. You can look at ratios of certain hormones and which are more prevalent in polycystic ovaries, so that can be a guide. But in terms of how we test, there is some really good using artificial intelligence work that's being done where they're starting to look at, I think, tests you can do on your saliva, which can be done at home. And then they're using test sticks, which AI can then use from a photograph to then be able to give a hormone level at that time of the day.
Is this on the NHS?
This is not available on the NHS, but this is just this is a very new technology that is an innovative technology that is recently being developed. And I think once we start to get more of these types of technologies, people will be able to test their hormones more regularly at home. They will be able to build up more of a picture. That data can then obviously then be researched across many, many, many women as well. And then we'll start to get more evidence and information about hormone levels, about fluctuations in hormones, about what's happening at different, for different women at different times in their cycles, at different ages, and perimenopause, postmenopausally. And that is going to be so incredibly useful to be able to identify how that might be impacting our health.
Yeah. I'm still thinking of that blood test that I've done for my hormones. I'm perimenopausal, but this is not a rosy picture. So I think they do these blood tests as a standard protocol, but this means that all the tests, these kind of tests done to perimenopausal women to check their hormones are useless, which leads us back to efficiency of operations again.
They're not totally useless in that they can sometimes give you clues. So you might capture a raised FSH level, which would be consistent with menopause. You might capture a low estrogen level, which might indicate, perimenopause. But the point is that you might capture that, and that might be helpful, but you might be having significant symptoms. But because you've done the blood test on the wrong day, because Tuesday is the only day you could do your test and you're busy and you're working, the day that you've had your bloods done, it's not going to capture that picture. And therefore it gives the wrong impression that you're not, that, as you say, it looks like you've got a completely normal profile, but it doesn't rule out that you may well be having these significant fluctuations.
Most of us feel moody, anxious, and sometimes totally off balance before our menstrual cycle. Give me your best tip to feel normal and half sane before my period.
Again, I think it goes back to those things that we discussed before. So it's about trying not to have any increased, if you're aware, if you have a regular cycle and you know when that is going to be, try not to have additional stress in your life at that time. Make sure that you're sleeping, that you're getting good sleep, making sure that you're eating a good diet. All of those things really are the main things that you can do. You can take hormonal treatments. You can take, if your symptoms are very severe, you can take antidepressant medication. You can take, there is some evidence that some supplements, some vitamins can be beneficial as well.
Yes,
and some of the B vitamins can be helpful. Magnesium can be helpful for sleep. So there are lots of different things that people can try that work well for them. Yeah, it's a difficult one, and how everybody copes can be quite different. So what can help for one person may not help for another. But certainly, I think if you're feeling a bit more anxious, which is quite a common, or a bit more stressed, then...
I'm now thinking maybe I should remove that calendar entry. It's probably making me more stressed that I'm aware of it. It's coming in a week.
Maybe, but then equally, maybe you'll think, that's quite a stressful thing. Therefore, I won't put it in for that week because I might find it difficult to.
So it goes back to lifestyle changes and trying to keep stress down.
Yes.
Can I take anything for this?
There isn't. I mean, there's medicines you can take if you're suffering with significant mental health problems, which may be causing stress, but there isn't a sort of stress is usually caused by factors in our life rather than actually caused by a physiological issue. So that's really where you need to explore more than we can become less resilient at coping with stress. And we know certainly before our period, we're often less resilient. We know perimenopausally and menopausally, you can be less resilient. And that means you don't cope with stress quite as well. So I think it's important to recognize that. But therefore, you might need to make adjustments.
Yeah, sorts out my life. I think I'm a prime example of what you're saying, because in my younger days, I had PCOS and I had a terrible period with pain. My mental health wasn't optimal. My periods were all over the place. And I'm talking my 20s, because I wasn't in control of all these things that you were mentioning. Now that I'm 46, me and my child, I make all the decisions. I'm super independent. I can control every aspect of life. My period for years now, I don't know what happened. It's just I sorted out the diet, the exercise, the sleep. My period is perfect every 28 days.
And sometimes that can happen as well as a result. Sometimes when you've had a baby, physiologically things can change as well. So there are other things that can change that. But I think, making those changes certainly will have been a hugely significant factor. Yeah.
Fiona, some women go through the very difficult experience of infertility and pregnancy loss. And it can be very emotionally demanding on the whole family. I myself had a failed IVF that led to miscarriage. And I remember in the follow-up appointment, when I saw the doctor, all she had to say to me is that we've burned your eggs. And that was the only explanation and words of comfort that I've never even heard that expression before. We've burned your eggs, that you had to tell me. So are you satisfied in general with the support women get when they face these life events?
I'm so sorry that you had that experience,
because that's a long time ago.
Yes,
but I had a child after
yes,
that.
No, but that's really sad. We know with fertility treatments that the amounts of counselling and support that they offer can vary from location to location. In terms of counselling and support that's offered, that can vary as well. I do think there is a very important issue which I think affects staff working within fertility units, but also works for staff working across the whole of the healthcare system, which is the issue of empathy fatigue and compassion fatigue. And I think that what can happen is simply that because a doctor is involved in highly emotional situations a lot of the time, just over a period of time and working in that environment, they do start to become unable to have the levels of empathy perhaps that they might have had before. And this can also be related in some part to being a bit burnt out, to being under pressure and all those other factors as well. But I think that's something that is really important to recognise. And I think we all as doctors and healthcare workers need to be conscious of that all the time, that, the doctor that spoke to you in that way, I'm sure she wasn't, or he wasn't in any way trying, they weren't deliberately meaning to say anything that would be upsetting. And perhaps what they were saying, they felt, well, this is just a term that we use medically and
she
not
was actually very cheerful and positive about it. And she didn't deliver it in a cruel way.
No, but it equally, it's just understanding sometimes and remembering that this is a patient in front of you that may be different to the other 10 people that you've seen already that day, and just trying to remember that empathy and compassion that's important.
Menopause. I'm 46, soon to be 47, in case I haven't mentioned that fun fact already. What should I know before I reach menopause?
It's just really to be aware of what that menopause is going to be an inevitable thing, that it will happen, and that it affects women all individually very differently. But it's important to be aware of the symptoms and experience that you may have during that process, which can start, as I said, from your early 40s. Even some people can be in their even younger years. And just having an awareness of what those symptoms are that you may start to notice, and what you may therefore expect as you go through that process. And then at what point, if you feel you need to, that you feel you can, what help you can access, what is out there to help you through that process, really.
Okay. But it's a sneaky progress. I say progress, let's call it decline. I don't want to sound pessimistic, but what are the physical symptoms or signs that I'm losing estrogen?
So you're right when you say it's sneaky, because what happens when you're approaching menopause, it's not that you're starting to reduce your estrogen and it happens in a beautiful linear curve. So you don't start off from one point and your estrogen just gradually and slowly goes down in a nice
as the
simple line.
Dictates.
Exactly. Yeah. And we just adjust to that. It goes more in a sort of pattern where you're having peaks and troughs. And that's why it can be very difficult. So you might have a period of time, maybe 2 or 3 months, where you are noticing some changes. And I will talk about what they might be, but you'll notice some changes. And then you might, for 2 or 3 months, feel perfectly normal like you did before, and you'll be fine. And then suddenly you'll start to feel those things again, and then you'll be okay again. So it can be very, very difficult sometimes to really put your finger on exactly, and a lot of people will think, well, that might be because of this and because of that. And, oh, this was a bit of a stressful time, or that happened at work and that's why I was feeling like that. So it can be very difficult sometimes to understand exactly what's happening with your hormones. But in the perimenopausal, there are so many different symptoms that women experience. When
you say perimenopausal, that's from which age to?
Well, perimenopausal is that time when your symptoms start to when you go through your very last period.
Okay, at the end of period.
So the end of your period, and then menopause is defined as your very last period that you ever have. Okay, right. So perimenopause is that period of time leading up to that point.
From which age, roughly?
This is the thing. So it depends when. So there are some women who will have an earlier menopause. They might stop their periods in their early 40s, in which case they may start to have symptoms in their late 30s. The average age of menopause is 52. Most people will probably start to notice symptoms maybe mid to late 40s, but that is it can vary from person to person.
And this is a perimenopause.
Yes, that's right. Yeah. So there are so many symptoms that women can experience. And the thing is, we have estrogen receptors throughout our whole bodies. And again, this is something that we need more research to understand how this can impact us. But it can affect us in so many different ways. So the common ones that I would say I see most in perimenopause tend to be anxiety, so mood changes. So a lot of people often say they feel anxious, they feel more overwhelmed. So they they would say, I used to be able to, do my job without any problem, and I've recently found I've lost my confidence. I don't really understand why. They may feel more on edge and not really having any particular reason why they feel anxious, but they just have that slight inherent anxiety feeling. They might feel angry or frustrated, similar to the symptoms that you might experience in a premenstrual time. So in that week before your period, often that can go on for a more prolonged period. You might notice those premenstrual symptoms are much worse than you used to experience. So around the time before your period, you might start to notice that those are, you're much more angry, you're much more anxious than you used to be. You might start noticing that you're getting, you might have a night sweat just before your period is due, or having sweats at nighttime. You might notice there are changes to your skin, to your hair. A very common change is brain fog. So a lot of patients will say, I just literally just cannot remember things. I'll be talking to somebody and I just completely lose my flow, or I can't remember somebody's name, or something that I would always, my PIN number, I just can't remember it. That's an extremely common symptom. And I would say the sort of anxiety, mood changes, brain fog, sleep disturbance is another one. So a lot of people find, not because they're having hot sweats or hot flushes or anything like that, but they notice that they just are not sleeping as well as they used to. They're waking up multiple times throughout the night, and again, not for any particular reason. They're not particularly stressed or worried. So those are the most common ones that I would say, but there are a huge number of other ones as well that sometimes, itchy skin, as I said, changes to skin or hair, funny aches and pains that they wouldn't normally have. And then the classic sort of menopause, hot flushes, night sweats, those tend to be actually a bit later on, those symptoms present, but they can present earlier as well.
So in a very overwhelming, stressful life, how would I tell that these kind of symptoms that come on and off are because of fluctuations in my hormones, or due to a troubled relationship with my husband, or naughty children, or stressful job? How would I tell? Because when I know, or when I'm able to speculate, I'll be able to seek help. Right?
Yes.
How do I tell?
This is the thing. It is really difficult to tell, because you can't test your hormone at that time to say, yes, your hormone is low, that's why you're feeling like that. We don't have the ability to do that. I think that will come, but we don't have that at the moment. I think it's just keeping a diary, tracking your symptoms. So, sometimes just keeping a note of where you are in your cycle and what symptoms you're experiencing, that can be quite helpful. And just having an awareness of what they are. So therefore you can say, well, I don't really understand why I'm feeling the way I'm feeling, because I wouldn't normally feel like this at this time in my cycle. And actually I've been feeling like this now for, several months, and this isn't, I can't really understand why. Well, it's probably going to be your hormones. So
I've noticed something. I know that hot flushes, which I get right now, but hot flushes are temporary spikes in body temperature, and not necessarily like a constant change in base temperature. But I have this feeling that I'm warmer over the last 2 or 3 years, that my body temperature has increased, or maybe there is some sort of perceived warmth. There are coats that I can't wear now, not even in winter.
Yep.
Is it just my imagination?
No, absolutely not. So we know that
bless you.
estrogen is involved in your internal thermometer. So when if your estrogen level is fluctuating or decreasing, that is going to affect your body temperature. So again, a lot of women will report that they feel hot. They have fluctuations in temperatures. They might get much more, sweaty and hot than they used to. They may have flushes, but generally a lot of people will say the exact same thing, and it's to do with hormones.
HRT, hormone replacement therapy, is a big, big subject for women in my age, considering it's one of the routes that we could take to get relief from menopause. How could I decide if it's the right path for me? What should I consider?
I think it's really the most important thing is to really think about how your symptoms are affecting you, and whether it's something that you feel you need to do something about or not, and how much an impact it's having on you. There are lots of things that you can do to help with perimenopausal symptoms that do not involve taking hormones. There's lots of alternative treatments out there. There isn't a huge amount of great evidence behind some of them, but there are certainly health supplements you can take. You can change your diet, exercise regimes. Some people find having counselling, so cognitive behavioural therapy, all of these sorts of treatments. There are other medications you can use for some of the symptoms of perimenopause as well. So you don't have to go down the route of hormones. But if that is something that you're interested to explore, quite often when I say to patients about the decision to take hormones or not, I think a lot of women often very reluctant. They're concerned that if they start on that route, if they start down the route of HRT, that they're going to be on that journey, and that's going to cause problems if they then want to change, or they worry that it's going to, am I going to get my symptoms going to be worse when I finish it? How do I stop it once I've started? The thing about taking hormone replacement treatment is that it is something that you can just try if you want to. So quite a lot of women, I will say to them, we can just try. We can start on a low dose and just see how you are. If you feel after 4 to 6 weeks that it is helping your symptoms, that you feel better on it, then great, you can carry on. If you feel that it's made a bit of an improvement, but you're not quite where you would like to be, we can always then tweak the dose and increase the dose if we need to. If it really makes no difference to you at all, then we can then say, well, perhaps this isn't the right option for you at the moment, and maybe explore other things instead. It is also very important to make sure that we are not just putting all symptoms under the umbrella of menopause as well. We need to make sure that we take a good history, that we perhaps explore other possible causes for your symptoms as well. That's really important. And just, have a conversation about it. The other thing, obviously, we have to be very mindful of is breast cancer risk. And so there are going to be some patients who may be advised that HRT really is not an appropriate route for them to go down. And I think sometimes those women can feel very worried and concerned about what's going to happen around menopause and how they're going to manage that, either because they've had a past history of breast cancer or because they've got a very strong family history or a genetic reason that puts them at high risk. It's just really being aware that there are other options. You don't have to be on HRT. There are other things that you can take which would help if you needed it.
I'm assuming that HRT is not a magic bullet. Is there anything I should avoid? What are the potential pitfalls of taking HRT?
There aren't many pitfalls. I mean, it obviously there is a very slight increased risk in breast cancer if you take HRT, so we know that. But aside from that, there aren't many other significant pitfalls. There are side effects you might have from taking additional hormones. Some people will not tolerate some of the preparations. And again, that can be a case of just changing different preparations. So instead of having an oral progesterone, you might switch to a Mirena coil or a transdermal, a patch or something like that. So there are lots of options that are available, and it's just really being aware of those side effects. But in terms of risk, oral forms of HRT, so tablet forms of estrogen, are associated with a slight increased risk of thromboembolic events, so blood clots. So we tend not to prescribe those first line. We tend to now use just transdermal estrogens instead. And most of the hormones we now use first line are body identical hormones. So these have the same biochemical makeup of our natural hormones. So they're as close to a natural replacement as anything we've had before.
They're called body identical hormones.
Body identical, yes.
These are the regular traditional hormones.
Yes, and this is what we tend to use now first line. Yeah.
Okay. We feel that we lose ourselves with menopause, and it's not just the loss of periods, not the physical changes. I don't think anyone will miss a period, to be honest. No. But it's the shift in emotional, mental, cognitive abilities that's of concern, and maybe how we feel about life, our children, partners, jobs, all the rest of these things. It's not pleasant. I'm curious about your thoughts on giving women more hormones than the recommended medical dosage. By the way, I don't know what the recommended medical dosage is. But I've come across this debate online, and I was curious, do I watch out for that? I see a doctor and he or she prescribes HRT to me. How would I know what the recommended medical dosage for me, for my age? And how do I navigate this?
There isn't any particular protocol that's out there that says you would start on this dose or you would start on that dose. I tend to have a conversation with patients about what they feel they would like to do, and it depends slightly on how their symptoms. If they're having very significant symptoms, I will probably start them on a higher dose of estrogen. If they're only having quite mild symptoms or are a bit cautious about starting hormone replacement, then I tend to start on a lower dose and then we work our way up. The highest dose of the highest dose of estrogen that we would prescribe would be equivalent of 100 microgram dose. You may be referring to there is a recent documentary and there is some discussion about prescribing estrogen above that licensed dose, so above that 100 micrograms. I think the concern is that there are some women who will be taking HRT and they will get to the 100 micrograms of estrogen and will still continue to have menopausal symptoms. And if that then happens, what we really need to do is then investigate whether they're not really absorbing the estrogen, or are they absorbing the estrogen properly through their skin? Some people will not absorb it quite as well as other people. Some people might absorb from a patch, not as well as from a gel or from a spray. So sometimes changing over the preparation. And then there are some women that we might say, well, if you're not absorbing it sufficiently, then we should switch to an oral preparation or something else. And we would counsel them about that. The danger in prescribing above the licensed dose is that we don't know what effect that higher estrogen level may have on the body. We don't know if it might put you at greater risk of other conditions from having the estrogen at that level. And I think the idea behind increasing above the licensed dose is because this question of absorption, and are women not having enough estrogen, that even though they're having a high dose, it's still not enough for them. So therefore they need to have more. Personally, I would prefer to check their bloods. That is a case where I would check what their estrogen level is doing. I would take a blood test. I would have a look at it and just see, is there quite a lot of women will come in and say, I'm not having enough estrogen. I feel I need more. And then when we check their blood levels of estrogen are actually very optimal. They're fine. But then sometimes we look at other things. We look at, is their testosterone level low? Maybe there are other things that are affecting them. Maybe we should look at other health issues as well. Are they low in vitamin D? Is their B12 right? We need to explore other things as well. So I think, it's a bit of a difficult one really, but I think generally, I'm certainly myself, speaking for myself, would prefer to always stick within the licensing and the guidelines, just because it's a bit of an unknown if you go beyond that level.
Yeah, so the main issue is going above 100 milligram of estrogen again, the lack of research.
Exactly. And it might be that we are all being slightly too cautious, and maybe, we're not treating women because we are being too cautious, but we have to, the first thing is we have to cause no harm, and you don't certainly want to be doing something that could be causing a problem. And I think some of them, certainly in the documentary I watched, the problem was that some of those women were not then being monitored and followed up. And this can sometimes be a difficulty when patients are having treatment that's being given privately. They sort of fall between the NHS follow-up and the private follow-up. And if some of these women were not then being followed up, perhaps they might not have been taking their medication exactly how they should have been, or, there's lots of different circumstances, then that's when problems start to occur. So
it's not an issue of not tailoring or personalizing care. Is there a scenario where you would go against the recommended guidelines legally, in a legal frame still?
Yes. I mean, testosterone is an unlicensed medicine. And again, I do happily prescribe it. I do prescribe it because for women. Yeah. And again, this is mainly because there just hasn't been very much research that has been done on testosterone. There are very few female testosterone products, but we do know that testosterone does play an important role in women's health and women's bodies, libido, cognitive function, sleep. It does have an impact. And we do know sometimes when we take blood results that women can have an optimal estrogen level, but their testosterone can be really, really low. And as long as we are keeping that testosterone within a normal range and it's not going above where it should be in a normal female, then I'm comfortable to prescribe that for a period of time to see if it helps. If patients find it's of benefit, then I'm happy to continue to prescribe that as long as we're monitoring it and keeping it within the female range. But we don't want to go above that range. And certainly if their testosterone level is normal, then we have to have a discussion as to whether, if there's going to be any benefit really in prescribing it. And I'm not so comfortable in doing it in that situation.
And when you check women my age or even beyond 50 for their hormones, what do you compare it with? Surely there is a baseline. I say surely, I don't know what I'm talking about, but compare it with what? Is there a certain range?
Yes, there's a range that you look at. So when you're taking a blood test, you want to see that their estrogen level is at a certain point. Okay. And that's that has been decided upon based on what we think should be an optimal estrogen level for the body to be able to function, and what may then give symptoms if your level falls below that level, what you want to optimize it to. Yeah.
Fiona, you're a GP partner in Rye Medical Centre in East Sussex. Before we start, what is the difference between a GP and a GP partner?
Well, we're all general practice. So a GP is a general practitioner. So the way that general practice works is that not all practices work like this, but we have a partnership. So in my practice, we are 4 partners, and we then have we are partners within the business of the Rye Medical Centre, and we then have an NHS contract, which is where we provide NHS care for patients. And as the partnership, we can then employ other doctors who are not part of the partnership, but they are what we would refer to often as a salaried GP. So we pay them a salary, but they're not actually part of the partnership. So we're all qualified to the same level. We've all got the same level of experience. It's just really to do with the business and how we run it. So the salaried doctors will not be involved so much in the running of the practice. The partners will be involved in that. The salaried doctors are just really to see the patients and to do the medical work.
Okay, so there are more management responsibilities. If
Absolutely.
You're
Yes.
Yeah. At Rye Medical Centre, you and your colleagues established a sexual health clinic. You told me that at that time funding was available from the CCG, which is Clinical Commissioning Group.
Yep.
Is that correct?
Yeah.
But after you guys navigated the bureaucracy and the funding limitations to make that happen, the service was decommissioned a few years ago due to, and I quote you, funding cuts and lack of use. I want to stop at lack of use. There weren't enough people to use the service.
I think it was a combination of the factors that the funding was withdrawn, but also just looking at how much it was utilised. And that, I think, was mainly because of where we are. So we're a rural practice and we are right on the East Sussex and Kent boundary. Okay. And for that reason, the idea was that we would set up a health clinic, which would then be used by patients from a wider area. Yeah. And I think what we realised is that patients from a wider area were not wanting to travel into Rye to be seen there. They would probably more likely travel into Hastings, which is a bigger hub and a bigger centre, maybe less anonymous, who knows. But it wasn't hugely well utilised, unfortunately. There were funding cuts anyway. It wasn't, it's not a service that money was given to then continue. Any service needs to be reviewed to make sure that it's obviously worth it. And we still offer full sexual health screening to our patients. It's just that we don't have a sort of dedicated clinic. Yeah.
I feel, I'm not sure whether it's just me being self-conscious, but our surgeries and health centres are so formal. They don't usually encourage this kind of conversation. Like there's a feeling of unease when they walk into a surgery. Maybe people don't smile enough. I'm not sure whether this is going to help or not, but very, very formal.
Yes.
But there is a system that it's called Anima that's now being used in NHS. I'm not sure whether this is Kent or just a national thing. It's a booking system that we can describe our symptoms, upload photos, and I think it's managed, this is my assumption, managed a little bit, but by AI.
Okay.
You put everything in there and you book appointments there. And instead of the dreaded conversation with the receptionist in which you would tell, it's a sexual thing. And, I think this might help a lot of women and men to just avoid the phone call and go straight to the GP.
Yes. We haven't, that hasn't been introduced to us yet, or I haven't had experience of that. But no, I completely agree. And I think, sometimes the receptionist will say to a patient, particularly if it's an urgent, they'll say, can I just ask the nature of of why you want to have your appointment? But it's absolutely fine to say to the receptionist, I'd rather not say, it's a personal issue that I'd rather not say. No patient should ever feel that they have to disclose information to anyone other than the GP in the
Of course, it's common sense, that line. It's a brilliant line, but we think that, they are doing their jobs. I don't want to be rude, these kind of things. So I sheepishly say what I want to say.
Yeah.
We women definitely feel that our sexuality is an uncomfortable topic. And that's definitely the case for me. How can we change the conversation so it's normal for me, to expected and expected for everyone around me, especially for those who care for me?
I think this is something that really needs to go back to probably our sex education and our knowledge of sex education right back from when we were perhaps at school. I don't know about you, but certainly my knowledge about my sexual education that I was provided at school was mainly talking about periods, maybe a bit about, babies and when they're born. And then we talked a lot about sexually transmitted infections and contraception. And that was really the only things we ever really discussed. There was no other discussion about any other element of a positive, sexual history. And if perhaps young people are exposed to that information at a younger age, that will open that conversation a bit more, make it more normal to talk about it. That would be better. But I think it's just really going back to exploring in ourselves why we feel uncomfortable about that, and why perhaps we feel that it's not something that we feel able to talk to a GP about. Again, maybe in ourselves we normalise things, or we think this isn't a serious health problem. It's not something that is, it's not something that, I'm going to die from, or it's not something, so therefore it's not really appropriate to raise this with my GP. And, that's a shame, because it is absolutely a very important thing, and something that we should be openly discussing more. So I think it's just trying to address those things in ourselves as well.
From a medical perspective, what do we need to understand better about women's sexuality?
Being aware of how that might impact women during menopause and perimenopause and postmenopausally. A lot of women experience symptoms, vulval symptoms of dryness and discomfort, and that can impact. And a lot of women won't necessarily raise these issues because they find it a bit embarrassing to talk about. I get a lot of older women who will quite often say to me in a consultation, you probably think I'm a bit old for all this, but, and then they'll tell me something that's happening in their sexual, sex life that is difficult for them. And, it's a shame that they feel that they have to say that before that they assume that we will have, our own beliefs and ideas about that. So,
yeah. Realistically speaking, should I be more realistic about my age when I think about my libido?
In terms of libido does generally tend to reduce as you get older, but it affects people very differently. So, and that's not necessarily the rule across the board, because there are so many things that impact libido. It can very much depend on where you are in a stage of life and who you're with, and what's happening in your life at that time. So it is important to be aware of that. We do know that hormones significantly play a role in libido, and we know that when estrogen levels drop down, and we know that if testosterone levels drop, that can significantly impact libido. So for some women, that might be their only significant symptom, and they might, again, not feel that it's something that they feel ready to talk about, but that is definitely something that can be improved with hormone replacement in some cases.
Someone told me the other day that if we all open up about our sexual and emotional issues, the system will collapse. Do you think it will collapse?
No, I would like to think not. I'm concerned about what all of these problems may be. I mean, are there a lot of people out there who are finding it difficult to talk about this? And that's a societal issue, isn't it? That's something that we need to explore a bit more. And there are some people who are starting to talk more about these things. But it's an interesting one. Yeah.
Some people, men and women, experience some sort of sexual dysfunction due to medication side effects, most famously antidepressants. How would you deal with this challenge in your practice? Do I have to fix an issue by creating another one?
I think it's just something that you have to make sure that you counsel patients about. So if I'm starting a patient on an antidepressant, I will always explain to them that is a potential side effect. And again, it is very much you have to tailor your treatment to the individual. And for some people, they will not feel that it's such a significant issue that it will prevent them from taking the medication. And some people will stop the medication because it becomes a significant issue. So I think it's just making sure that patients are aware that is a side effect of a medication that they're taking.
Breasts. Let's move to breasts a little bit, please. How often should I check my breasts for any abnormalities?
It's recommended that you should check your breasts at least once a month. At least once a month. And you should certainly make sure that the two things you should do. One is that you should look at yourself, look at your breasts.
Visually in the mirror?
Visually, yeah. Okay. So you should always just look at your breasts, look to see if there's any signs of the skin looking different, if there's any puckering, any skin changes. Are the nipples looking normal? If there's usually symmetry, is there still symmetry? If there's normal, a bit of asymmetry, which is also quite normal, but that would be normal for you. So just understanding what looks normal to you, what your breasts look like, being familiar with that. And it's amazing how many women will not do that because they're self-conscious looking at themselves. And the second thing is then just to examine your breasts. And a lot of women get very worried about this and say, I don't know how to feel my breasts. I don't really know how I should be examining myself. There isn't really any huge right or wrong. I mean, we generally say try and just palpate the breast with the sort of palm of your hand with your fingers. But often just in the shower or the bath, just as long as you're just feeling the breast, getting to know what feels normal for you, also feel up into the armpits as well, if there's any lumps in the armpits. And that's just something you should just really try and do at least once a month. You don't need to do it every single day, but a minimum of at least once a month.
Okay. So I look for the structure, for lumps, of course, I know this one, the color, the shape, this kind of any abnormalities.
Skin changes, anything that just doesn't seem normal to you should be checked.
Okay. Yeah. I'm assuming that my breasts are like any other body parts, that they change over time with conditions, with age. What are some of the common but harmless changes that I might see in my breasts?
So breasts generally become less firm as you get older. Certainly after
that part, the sagging effect.
Yes, certainly after having children and breastfeeding, some of the skin, the skin around the breast and the connective tissue within the breast can often change. So breasts do change they can feel less dense and they can slightly sag, I suppose.
Yeah. I slightly feel, I feel a little bit of ache in my breasts before my menstrual cycle. Yeah. And I never thought much of it because it's every month, so it should not be ominous. This is normal.
It is normal, yes. So it's very normal to get breast pain. Again, it's under the influence of different hormonal changes that can occur in the breast, and that's completely normal. But if you have a persistent pain in the breast, then that is something that should be investigated. Breast cancers normally present with lumps, but obviously any pain in the breast is very important to also be investigated, because that can sometimes be the sign. You can sometimes have abscesses. Sometimes you could have a cancer that could present in that way. So it's just anything like that should be checked. Okay. But yeah.